Hi, I'm Teresa Baker from the ICU. We're going to go over the procedure of a Swan Ganz placement today and all the things that nurses are responsible when it comes to Swan Ganz placement. We have a patient here that has a history of congestive heart failure and now he's admitted with septic shock. The doctor has determined that the patient would be better served to place a Swan Ganz catheter to be able to better treat the patient for a better outcome. So it is up to us to get those supplies ready and get the setup ready for the doctor to insert the Swan Ganz catheter. First thing that we should do is to go get the procedure cart. You can get your supplies off the procedure cart, but my preference is taking the procedure cart and putting it in front of your room so all your supplies are there. If you've forgotten something or you need to have a duplicate supply if one gets contaminated, it's right there at your fingertips. So first we will take the supply cart to the room. Okay, so let's look at our procedure cart and see what's on here that we're going to need for our Swan Ganz. Especially the thing that you need to check on, number one, is that you have the triple lumen catheter kit. It has all the things you need for sterile procedure. It has the mask and it has the hat that goes over. It has gowns, it has gloves to keep things sterile. On the cart also is extra hats and gowns and gloves if they have assistants that are helping with the procedure. You will be helping with the procedure, so you should do the same. So there is replacement for all these things right here on top. Also in here is lidocaine and chlorhexidine and everything to prepare the site for the Swan Ganz insertion. Also in here, is this it? Is the box that comes with the Cortez that you're going to need for your Swan Ganz catheter. It's the blue arrow and it says percutaneous sheath introducer. This is the one that has the Cortez that you're going to need for your Swan Ganz. Make sure you have that in your cart. Also up at the top, there is a pressure bag. You will need a pressure bag to put on when we get in the room. We'll show you that. There also is some tubing for the Swan Ganz catheter. See, it looks like this on the outside. It's just white and gray, and it has lots and lots of tubes on it. That means it's the Swan Ganz catheter tube. It has a lot of little spots and lines in it. That's how you'll recognize that it's for the Swan Ganz. The Swan Ganz catheter itself is right next to it. It's yellow, has a red cap syringe, circles around. It says right on here, Swan Ganz. This is the catheter you're going to need. There's also cardiac output, syringe, and tubing here that we will show you how to set up. Also, we always use gauze. They also use sutures, and they are in the second drawer. You may have to bring some extra gauze for the doctor when he puts in the Swan Ganz catheter. So everything that you need, there's two things in here actually that are not on the cart. One is a sterile bowl that you're going to put sterile water in for injection, and also there is two 500cc bags of normal saline that you'll have to get with you too. Now let's go to the room. Okay, here we are at the bedside. We have a lot of setup to do before the doctor comes in to make the placement. You're going to get the large tubing package that I showed you earlier and open that up, and we're going to prime that tubing. This tubing requires a pressure bag. Always save your little tags here for labeling your tubes when you're done. Set them aside. That's what I always do. And so this is a lot of tubing, so you're going to have to start taking it apart and try to find where the top of the tubing is that's going to inject into your normal saline. I always clamp this for safety at the beginning because it's going to start priming your whole tubing before you're even ready. So we're going to get a 500cc normal saline bag, open it up. Here we are with our bag and our tubing. We're going to take it and we're going to puncture this normal saline. And now we're going to put it in our pressure bag into the net part and hook it through the top of the bag. And just hang it on your hook here nearby. And now you're going to make sure there's fluid in your dropper, and you're going to pump up your pressure bag. Our rule of thumb is once you get to the green color here on your monitor, your pressure bag, it's usually enough pressure. It gets tighter and tighter on the normal saline because you need to have pressure on that normal saline. It takes a while sometimes. It's almost there. There's the green color. Now I'm going to lock pressure. And now I'm going to prime this tubing. You can use any receptacle to prime. See all these spaghetti tubings here? It takes a little bit to try to figure out what they are doing. And so here's only one line from the pressure bag. It comes down to this and it bifurcates to two different places, as you can see. Bifurcates to this side and to this side. So we need to make sure all of this is primed the whole way through. And so I'm going to open up the clamp and I'm going to prime one side and then the other side. I usually prime this side first. See, there's two little tags here. I'm going to find the end of this tag. This is really crazy, guys. But this is how it is. And I'm going to suck until this fluid comes through here and through the end of this tubing. See, there it is, right through the end there. And now I'm going to prime this side over here. And it's going to come through this other one. And now there's an archway between the two, a branch. You're going to turn this off to this side and do it again because now I'm going to get this air out of the branch that comes across and it's going to come through. And just watch your tubing, make sure you have all your air out. Okay. Now that you have everything primed, you leave these little white stickers on the end of them to keep your ends sterile. Now you find this cord that goes to a pressure box. You look up here, it says pressure and it's the maroon colored box and the gray cord. You're going to find the end of your gray cord and you're going to hook it up here. Just like your art line does, just like your other central lines do. And if your patient were laying in the bed, you were going to zero this to the left atrium height, just like you would any other central line, and you do it on your monitor and zero it before you place it in the patient. Now it's ready to be hooked up to the Swan Ganz catheter. So now we're going to the next step. We have our sterile bowl here. We're going to go ahead and take the lid off of it. And we're going to put sterile saline in the bowl. You will not use the saline for irrigation for this bowl. It has to be from your IV bag. And you have to use sterile scissors to cut the end of it and fill up your bowl. So you cut the end off here and you fill your bowl. Half full is fine, you don't need more than that. So that's prepared, you leave that to one side. And the next thing is we're going to get the Cortez kit. We have the central venous kit ready for the doctor to open. And this is the Cortez kit. We're going to go ahead and look inside. We're going to be handing this to the doctor when the doctor is sterile. One of the important, instead of just sterile by the insert side, the patient has to have a sterile field like the size of the bed, like a half sheet drape over the top of them to keep everything sterile because there's so much area that needs to be sterilized. So we're going to open up the kit just for education's sake. We wouldn't normally put this on the sterile field, we would keep it separate. And we're just going to look and see what's inside of this kit. Here's another sterile drape. And here's our Cortez. This is what the doctor's going to put in. See, this Cortez has blue on it, white with blue. That means that it's the one that's used for a Swan Ganz. I take this out. This is where the doctor will insert this into the internal jugular or the subclavian vein on the chest of the patient. Once it is in there, they're going to prepare the Swan Ganz to go inside and just drop it on the sterile field. You won't be touching anything except the very ends of this Swan Ganz. You will not be touching any other part. Right here at the ends is you have to hook up the tubing to the ends of these Swan Ganz. And if you look at the ends of them, all of them say what they are. The yellow, that's just yellow, it says PA distal. This one says proximal infusion. It's the white tube, and this is the yellow tube. The blue tube says proximal injectate. This is a pressure cable, and this is for your balloon catheter. So here's your little syringe, and you open it up, and it can only hold 1.5 cc's of air. It goes on here. That way you don't overinflate your balloon, and it has a little red line right here. See the red line that says that the balloon is locked? When you're ready to inject the balloon, you push it the back and the line is straight. And if you look at the end, we're going to push the balloon up. There's the balloon. And you let it go, and it goes out all on its own. Don't push too hard. You're just going to push easy, slow and easy. Because the balloon with too much pressure too fast could break. So you have to check that balloon before the doctor inserts it. So one of the things you can do is inject it here, and you want to make sure there's no leak. So you would have the doctor put the balloon in the saline to make sure no air bubbles come out of there, so that would show a leak. So then, now that I have the syringe on there, I'm going to press lock again. So we're going to go to these other things to hook up our tubing. This is in our patient. So you find the end connector that has yellow on it. Go by the colors. And you're going to find the yellow tube and hook up the yellow to the yellow. Now you're going to find the one that has blue connector on it, and you're going to connect it to the blue connector. There are only two connectors on here, the blue and the yellow, so it shouldn't be too hard to get that mixed up. The other one is just like an IV, so you would get a syringe of normal saline. I'll get a fresh one out. And you would put this on the end, and you would prime this line. So if you look at the end here, if I'm pushing this, you'll see there's a little hole here, and the saline primes here. Now that the other ones are hooked up, the yellow and the blue, I'm going to go over here to flush these, and I'm going to flush the yellow. And the yellow, as I pull this through, can you see it coming out at the end of the catheter? That one's flushed. And now I'm going to flush the blue one, and that's the other little pigtail, and it's further up here, right under my fingers, right there. So now your catheter is completely flushed. There's no air bubbles in your catheter. Inside this Swan Ganz are 3 different lumens in this very small catheter. One lumen empties here, one lumen empties here, and one lumen empties here. 3 different spots. And also, of course, the balloon at the end of the lumen also. Just to relook at that, there's the balloon. Okay? All right, so you have everything hooked up except for the cardiac output. You would do that after the Swan Ganz is in. This is the protector before the doctor inserts it, just like the pacemaker. Then with sterile gloves, they're going to stick this catheter down through this protector sheath till it comes out on the other side, and then they're going to move it on like this. So when he's done, he'll pull it up and it'll protect whatever's left of the Swan Ganz on the outside of the body. So the doctor is ready to insert the Swan Ganz in the little trap door. Remember this little trap door, when you put something in it It opens. When you take something out, it closes, so no air goes into the patient. So you insert, not you, the doctor inserts the Swan to 20 centimeters. 20 centimeters is 2 black lines right before it goes into the sheath. Once it gets to 20 centimeters, it should be the length into the right atrium. Then the doctor will say to up the balloon. You'll open up the balloon syringe and put the air in the balloon. You will hold it down until the doctor says balloon down. You'll open it and let the air go out. When he says balloon up, you push it in and you will hold it until the doctor says balloon down. So now you're going to continue to run it through. So as the catheter goes, let's refer over to our education. So here's the cardiac anatomy. So if you're putting the catheter in the IJ, it's going to come in the superior vena cava, the end of your balloon. And your balloon, they're going to continue to send it down, and it'll go right to the right ventricle. Then it will curve up with the flow of blood, go up through the pulmonary valve into the pulmonary artery. That's the goal for it to be placed. And if you look over here at this other one, you're going to, as the doctor is inserting this catheter, you look up on the EKG because we have hooked it up to the pressure cable, and the pressure cable will give us a note on there, which we'll look at later. But if you look at, once the catheter gets into the right atrium, you will get this waveform. Once the catheter gets into the right ventricle, this is the waveform you will get. Once the catheter floats up into the pulmonary artery, this is the waveform you will get. Once it continues to go up into the pulmonary and wedges up here into these very small pulmonary arteries, you will get this type of waveform. And that's what you want. Because as soon as you get this waveform, the doctor will say, take the balloon down, and the balloon will be deflated at that point, and the catheter will be left in place. If you look up on here, you'll also see how the catheter goes in to the right atrium, the right ventricle, through the pulmonary artery valve, and into the pulmonary artery in wedges. And this is how it shows how the tubing and catheter that we've just shown you is all hooked up. There's another picture up here which also shows our normal saline in the pressure bag and all the tubing and how that continues to go up into the heart. Okay, then after it's all placed in the correct place, the doctor will call for an x-ray. And this is what you're looking for in the x-ray. Because since there's 2 pulmonary arteries, a left and a right, your x-ray may look a little different. So if it goes in the IJ, comes to the right atrium, right ventricle, swings around for the pulmonary valve, and it's turning towards the right pulmonary artery. On this picture here, even though it's not an x-ray, you can trace it, go through the pulmonary artery, and actually goes to the left pulmonary artery wedge pressure. Shows you how the balloon is wedged up there. And then the way you're going to know, because you can't see inside the heart while you're doing it, is your waveforms. And so if your waveforms don't come correctly like they're supposed to, then you're not in the right place and you might have to withdraw and try again. But until they're in the correct place, you can't do the measurements you need for a Swan Ganz catheter. Okay, let's look back at our catheter again. Once the doctor has it placed in the place that he wants and our balloon is down because we're in the correct place, you never leave this balloon up because that means this catheter is wedged in the pulmonary artery. We can cause an infarction, which would be deadly to the patient. So the balloon has to remain down only when testing after this. So you're going to notice that these markings are on this catheter. And so when the doctor stops, here's the skinny lines mean 10 and the fat line means 50. So if you're going all the way in between the fat line and the 4 skinny lines, you're at 45 centimeters. If you need to go further, this is a fat line and a skinny line. That's 50 plus 10, that's 60. You're at 55 centimeters of length. You need to make sure you chart this on the patient's chart and on your board. So if for some reason your waveforms don't show up anymore, you can notice that possibly this thing has been pulled out. The doctor, after he gets it in, will advance this, and there's a little lock on this catheter, and it will lock, semi-lock, and then this will cover up the rest of the catheter to keep it sterile. All right. So this, as you see, it can be moved inside, so you need to make sure you know where that catheter is. And keep an eye on that number for him. Now, this hanging here, we call this a pigtail, and what it is basically is another IV access for you. You can use this for IV fluid or medications or anything like that. Also over here on the catheter, now that we have all these other ones set up, the one that has a syringe, you can just put a hep lock on the end of it and use it for IV fluid also. All right, now we're going to hook up the cardiac output now that the patient, when it's in place, you need to get a chest x-ray. And the chest x-ray, like I showed you on the education board, you need to get that before you actually do your measurements or anything further. Once it's in place and it's confirmed, then we're going to hook up the cardiac output. Chest x-ray, that's confirmed our placement. So we're going to hook up the cardiac output. This is the package. It has tubing and a very large syringe in there. So we're going to open that up, and we're going to open our next bag of normal saline. It can be 250 or 500, whatever you have. In here again, you're going to have to unround this whole amount of tubing right here. Open it up. And on the end, here's an injection site. So I would clamp it and hook it up to the normal saline. We're going to hang it up here next to our other pressure bag. And I'm going to take this syringe and I'm going to put it on the end here. And this is a special way to prime. We're going to unlock it. And what I'm going to do is I'm going to turn this stopcock off to here. And I'm going to pull the saline out of this tubing into this syringe. It's kind of a different way of priming than let the air out. Pull more. See, we're starting to get a little bit of fluid now. All the air is out of our tubing. I'm going to push the rest of the air out. And I'm going to fill up my syringe, making sure there's still no air in the, because we're going to inject this into the heart, and we don't want to inject any air into the heart. So after we've done that, we're going to hook it up to more monitors. Here, if you look, it says CO, which is cardiac output. If you look at the box here, it's orange. The tubing is, the cable is orange, and the connector is orange. If you're colorblind, ask somebody else. So, the black part of this cable hooks right here on this little piece here that hangs down. It just snaps right on. This is the thing that checks the temperature of the injectate when it gets into the heart. We'll talk about that later. And on the other end of the cable is a connector that goes on this connector here. Together, these two are going to measure the temperature inside the heart, and it will time out how long it takes me to push this colder fluid into the warm heart over a certain amount of time, and it will do a calculation on my monitor to tell me what the cardiac output, and it's all done by the temperature of the injectate. If your temperature is too warm, like close to the temperature of your body, then it won't give you an accurate reading. You can always get cooler fluid if you need it. You can put some in the refrigerator if you need to. If your patient's temperature is too cold, then you need your solution a little bit cooler. But most of the time, you just need regular room air temperature saline. Now you're ready to hook up the cardiac output syringe. You're going to go to the blue stopcock, take the end off. You've already got this primed prior. You take the end off, and you're going to screw it onto this portion right here. And then you're going to turn this stopcock off to this side port. Now, if you want to, you can use this side port to put a hep lock on or something like that and use it for an extra IV site. It's no problem if you want to do that. So now what we're going to do is inside of the heart on this Swan Ganz, down here, if you look and see where the fluid comes out, I'm going to push this fluid. A little bit of fluid from this syringe. And you're going to see this fluid is going to come out at the beginning of the catheter. Well, the beginning of the catheter is in the right atrium, so I'm going to inject this full amount of blue fluid into the heart, and these little catheters are connected to the end of this catheter. And what it will do is it will count how much time this fluid that I injected gets to the end of this catheter, which is in the pulmonary artery. And through that calculation, it will tell me how fast this cold fluid got from here to here in the heart, and thus doing a calculation of what the cardiac output is for the right ventricle. So if I want to do another measurement, I can, and I can draw more fluid. And this fluid, if you double check and look back, as I hooked it up over here, is coming from this bag right here. So I can pull it up and get more fluid, and I can inject it into the heart. You have to be careful though. Make sure you turn your stopcock off before you pull it up, because if you pull it up, you're going to end up pulling up blood from the heart. So you want to make sure it's turned off to the heart. So when you're ready to do cardiac output and your readings, you want to do a PA reading, a CVP reading, and a cardiac output reading. You're going to go to the monitor, and you're going to go to monitor setup, and you're going to push that. And over here on monitor setup, there's a thing that says cardiac output right here, so we're going to click it on. It will give you a drop down screen that says cardiac output here, and it will give us a measurement. It says here ready for measurement, and it has a temperature of what, because of this catheter and this temperature that's in my catheter, it says what the injectate's temperature is and what the patient's blood is here. So it's able to compare the differences of the blood temperature. So when you're ready to do your cardiac output, you're going to push start cardiac output. But there is a little trick to it, because you need to wait till the patient's end expiration. So they'll take a deep breath, and when they're finished blowing out, you will push start cardiac output. So taking a breath in, end expiration, start cardiac output, and then you hear the beep, and then I'll push my syringe as fast as I can, and then stop. A scale will come up here. It's actually measuring, even though it's not in a patient, because it's measuring the temperature at the end of this catheter. And it's going to say this is when it started and how long it took to get through that catheter. And then in a second or two, it will give me a number to say how much the cardiac output is. But it looks like it's not stopping because it's actually not in the patient. But it will give me a cardiac output on here. And depending on what it is, most of the time you'll do more than one. You'll do a second one to make sure they are consistent. If you get one is very low and one is really high, you do a third one and try to get the average of the the cardiac output. And so when you're done, you'll do hemo calculation. You'll write your cardiac out, you'll type it in, cardiac output here, your heart rate, your blood pressure, the PA pressure that we're going to monitor, and the CVP. It also takes your patient's weight and height in centimeters and kilograms, and it does a calculation to see how good your cardiac output is, what your PA pressure is, and your CVP. The one that we did not do is a wedge pressure. So if you're going back to the patient, then we remember the balloon that I told you about that's at the end. We also are going to do a printout of all of these. So when it's time to do CVP, When it's time to do PA pressure, we're going to push recording. Here where it says recording, and it'll say PAP, which is pulmonary artery pressure, and we'll push that. We'll do a recording of the CVP, and then we'll do a recording of the PA pressure. And how you will do that is you're going to turn this monitor over here. When you want to do a PA pressure, it stays open here at the bridge. When you want to do a CVP pressure, you turn the PA pressure off and it does the CVP pressure, just like that. So when I want to do wedge pressure, I leave the PA open. Make sure I have a PA waveform here. And then I'm going to push my syringe of my balloon open slowly till it comes up. And then I'm going to look at my waveform to make sure it's wedging. And when it's done wedging, I'll make sure that it's recording here. And then you record it for about 6 to 7 seconds is all. And then you take your syringe back down, because if you leave it up too long, it can cause problems with your patient's flow to his lungs. And so then you lock it again. Let's go back to the board. Okay, let's look at our board for our waveforms. This is the one that's going to be the CVP, or the preload tracing. That's with the blue. You're going through the blue catheter, and then you're going to close it off. You're going to open up the yellow catheter, which is going to give, it'll bypass this one because we're past this one now, but it's going to give the PA, which has a systolic and a diastolic and a necrotic notch here. That's the PA pressure, because that notch is caused from a close of the heart valves. And so after you get there, this is your PA pressure you're going to monitor. And this is how you know if it's wedged, because it looks like this on the monitor. And when you up your balloon, you should have a change that looks similar to this, very small, actually very similar to the CVP monitoring. But after you open the balloon, you should see this change. If you don't see the change, then you're not getting it to wedge like you should to get the correct monitoring. So the CVP, when you're going to measure it, there's numbers on the side of your paper, your EKG paper, and it has numbers here on the side. And you're going to measure what this line is, the low line versus the high line, and you're going to take the mean, which is the middle. That'll be your CVP. A normal one is from 0 is up to about 8. And then you're going to measure the PA. You're not going to measure the ventricle. You're going to measure the PA. So that gets the systolic, which is the high number, and the diastolic, which is the low number. And you're going to write the systolic and the diastolic, and then you will do the mean also. And it's all those numbers you're going to put in the monitor. Then you're going to measure the wedge pressure, just like you did the CVP pressure, the high and the low, and take the mean measurement, and that will be your wedge pressure. So the CVP reflects your preload, or the pressure in your right atrium. The PA measures the pressure in the pulmonary artery, which reflects the pressure in the lungs. Your pulmonary wedge pressure mimics the pressure in the right atrium and ventricle, because you cannot monitor it directly because we're on the venous side of the heart and the left ventricle is on the arterial side of the heart. So the only way that you can actually get an accurate reading of the left side is when you wedge it here, and when the valves open on the left side of the heart, this will do a measurement. This is the opening and closing of valves here, and that's why you take the mean. That will be the pressure that's on the left side of the heart, so you can see what the left ventricle is doing. The only time that this doesn't work correctly, if you have real high pressures in the lungs, or if your mitral valve or aortic valve don't open and close correctly. If they have some problem with those valves, you may get an erroneous number. So that's why it's always important to take the information that you get from an echocardiogram to give you an accurate EF of the left ventricle, and actually it will give you a pressure, an estimated pressure of the right ventricle, RVSP, to see right ventricular systolic pressure also. So make sure you get a good echocardiogram and those Swan readings together to get an accurate picture of what the heart is doing and the intervention that you need to take to optimize your patient's ability to recover from their illness. Okay, so in closing, what we want to do is check to see if we have any troubleshooting with the Swan's catheter. It can be very helpful with the treatment of a patient, but can also be harmful. And our number one rule is not to cause harm. Number two is to help our patient. So you look and see what the doctors order as far as frequency of your settings go. So before you start your settings, make sure you flush your catheter and zero it before you do your measuring. And you're going to zero the transducer at the right atrial or the left atrial site, just like you do your art line, like you do your CVP. And then when you need to check your catheter for your measurement. Do it, 2 or 3 times a day to make sure your measurement is correct. And when you look at your monitor, that your monitor will have a PA reading when the Swan Gan's at rest. Every time you look up, it should have PA. It shouldn't have anything that looks like a wedge pressure. If you see something that looks like a wedge, you need to problem solve, make sure you didn't leave your balloon up, or make sure it hasn't migrated further down into the pulmonary artery, so that way you would check your measurement to make sure that didn't happen. Also, the Swan Ganz could work its way out a little bit and could land in the the right ventricle, and that could cause you to have arrhythmias and PVCs. So if you start suddenly having PVCs where you didn't before, your catheter may have slipped back into the right ventricle. Also check your site. Make sure everything is nice and clean and dry. You would change that site every Monday, just like any other central line, or PRN if there's any soiling or loose dressing. When you inject your fluid for your cardiac output, you need to keep track of that and add that into your I&O at the end of the shift. And after you do your readings, you're going to print them out and you're going to show them to the doctor. When you do your readings, you also will run those strips and mount those on a paper and write them on there too as a permanent part of the chart. So show your numbers from your Swan Ganz to your doctor, how often he wants them done, and to report those to him. They may need to have a change in order of treatment for the patient depending on those numbers. So have fun with your Swan Ganz. It's a great tool, and make sure you're all safe out there. Bye.